Now, adjuvant therapy following pancreatic duodenectomy. 12 prospective RCTs in patients with the localized pancreatic ductal adenocarcinoma that has tested the efficacy of the chemo, radiation, single agent, multi agent, regardless of the final pathology stage. Adjuvant therapy is recommended for all patients who undergo upfront resection for localized pancreatic ductal adenocarcinoma and are otherwise conditionally acceptable candidates. The role of adjuvant therapy in patients who received a neoadjuvant therapy is not clearly defined. So those who have received neoadjuvant, in that patients, the role of adjuvant therapy is not defined. Although retrospective studies have examined the topic and will be discussed. So there are trials of adjuvant chemoradiation. First is GITSG, that is gastrointestinal tumor study group. It was a phase 3 study of 49 patients treated between 1974 to 1982, randomized to surgery alone versus surgery plus adjuvant chemo and chemo and radio. So patient with chemoradiotherapy, patient who received chemoradiotherapy, that is 40 gray split course with 20 gray in each course with 2 weeks in between the course, and bolus of 5 FU was administered daily for 3 days of each radiotherapy course and a weekly for 2 years maintenance therapy. Weekly for 2 years maintenance therapy. Patients treated with adjuvant chemoradiotherapy had improved OS 20 versus 11 months, and the study was limited by a small size sample size. It is unclear whether the survival advantage has been the treatment arm or as a result of a combination of chemo, radio, and maintenance chemo or one of the treatment. And this landmark study has established the role in the adjuvant chemoradiation as an acceptable treatment for resected pancreatic ductal carcinoma in US. So it is GITSG, gastrointestinal tumor surgery group. Now second is EORTC. It is European Organization for Research and Treatment of Cancer, conducted a phase 3 EORTC 40891, in which included 218 patients of pancreatic ductal adenocarcinoma, randomized to chemoradiation 40 gray split course 20 gray per course 2 weeks apart with continuous 5 FU of 25 mg per kg for 5 days, maximum of 1500 mg per day during first radiotherapy course and 035 day during the second, depending on the toxicity from the first course. No maintenance 5 FU was given. Observation following pancreatectomy. The primary endpoint was OS, which was similar for patients who received adjuvant chemoradiation and those who were observed. A long-term follow-up confirmed the lack of benefit from adjuvant chemoradiation. So lack of benefit from adjuvant chemoradiation. Now there is a European aspect 1 underwent complete macroscopic resection of the localized pancreatic ductal adenocarcinoma. Chemotherapy bolus of leucovorin 20 mg per meter square followed by bolus of 5 FU 425 mg per meter square for 5 days, repeated every 28 days for 6 cycles. And chemoradiation 40 gray split course bolus with bolus 5 FU 500 mg per meter square on day 1 to 3. Combination of chemoradiation followed by chemotherapy, and median OS was assigned to any of the chemoradiation was less than those who received no chemoradiation. Survival estimate at 2 and 5 years for 29 and 10% for those with treated with the chemoradiation, and 41 and 20% for those who not treated with any chemoradiation. So median OS among patients who received any chemoradiation was better. Chemotherapy. Median OS was among who received any chemo was better than those who did not receive any chemo. And 2 and 5 year estimates were 40% and 21% was for those who received chemo, and 30 and 8% for those who did not receive chemo. Study criticized for multiple reasons like complex design, lack of radiation quality control, and split course radiation, 9% protocol violation, 60% local failure rate, but established chemotherapy alone that has an acceptable adjuvant treatment approach. So then comes chemo trials, adjuvant chemo trials. So now we are clear that there is no role of radiation, but there is a role of chemo. So there comes CONCO 001 trial, and it was a phase 3 RCT. 368 patients of resectable pancreatic ductal adenocarcinoma received adjuvant 6 cycle of gemcitabine 1000 mg per meter square on day 1, 8, 15 of 4 weekly cycle, and then compared to observation. The primary endpoint was DFS, secondary was OS, toxicity, quality life, and reached the point with the improved DFS of patients who treated with the adjuvant gemcitabine, but median OS was similar. In a follow-up report of long-term outcome, 5-year survival was improved with the gemcitabine arm, with a grade 3 for toxicity was rare, less than 5% in the treatment arm. So this study establishes gemcitabine is the standard and well tolerated for adjuvant therapy, and which is likely benefit 10% of the patients with the pancreatic ductal adenocarcinoma. Then come aspect 3. Aspect 3 is a RCT, resected pancreatic ductal adenocarcinoma, who were treated with adjuvant gemcitabine of 1000 mg per meter square on day 1, 8, 15 of every 4 weekly, or 5-FU, and folinic acid 20 mg per meter square folinic acid bolus, followed by 425 mg per meter square 5-FU on day 1 or to 5 of every 4-week cycle. The primary outcome of OS and similar between the treated with gemcitabine. It was similar between the treated with gemcitabine alone or compared to 5-FU. And secondary outcome was toxicity, progression-free quality of life. Adverse events were more in patients with the 5-FU. And median progression-free survival similar, quality of life. Based on this result trial, gemcitabine, this was referred to as the adjuvant regimen, approved, given it improved toxicity profile. So gemcitabine is the standard of care for adjuvant chemotherapy in case of pancreatic ductal adenocarcinoma. Now the radiation RTOG 9704, it conducted a phase 3 trial. Patients undergoing efficacy of the systemic 5-FU, that is 250 mg per meter square daily, or gemcitabine 1000 mg per meter square weekly for 3 weeks, 1 cycle before and 12 week after 5-FU cycle of 250 mg per meter square daily for every 4 weekly, and 2 week off. Gemcitabine 3 cycles 1000 mg per meter square every 3 weekly for 3 weeks and 1 week off. 5-FU based chemo radiation 50.4 gray 5-FU 2 mg per meter square daily throughout the radiation in patients with resectable pancreatic ductal adenocarcinoma. Total treatment period of 6 months. So total of 451 patients were included in the study, and primary endpoint was OS. And for patient OS was similar with the gemcitabine and 5-FU arm. Patients with the pancreatic head tumors, those receiving gemcitabine, had trend of improved OS. And the site of first relapse was distant in roughly 70% of the patients, and local region in 30% of the patients. So this was aspect 3 RTOG. Now aspect 4. Aspect 4 is a phase 3 RCT with the compared adjuvant gemcitabine 1000 mg per meter square day 1, 8, 15 of every 4 weekly cycle, alone or in combination with the capecitabine 1660 mg per meter square daily taken by mouth for 21 days every 4 weeks. Patient with resectable pancreatic ductal adenocarcinoma. The primary endpoint was overall survival for randomization to death of any of the cause. Total 730 patients were included. Intention to treat analysis, and the median OS was doubled in the double arm, that is gemcitabine plus capecitabine. It was better as compared to monotherapy arm, and the 5-year OS was 30% in the treated arm with gemcitabine capecitabine compared to 20% for gemcitabine alone. And given the improved survival of the patients treated with gemcitabine nab-paclitaxel compared to gemcitabine alone, MPACT trial. So APECT in the metastatic setting we'll discuss. Now APECT was a phase 3 RCT designed to study the efficacy of the double regimen nab-paclitaxel 125 mg per meter square, gemcitabine 1000 mg per meter square on day 1, 8, 15 of every 28-day 4-week cycle compared to gemcitabine alone as a monotherapy 1000 mg per meter square day 1, 8, 15 of every 4-weekly cycle. And 866 patient of chemotherapy new patient who underwent complete macroscopic resection in the pancreatic ductal adenocarcinoma included. The primary endpoint was DFS, secondary endpoint OS. Most patients compared the 6 recommended cycles of both arm, and median DFS assessed independently. So investigator assessed independent review treated with the gemcitabine nab-paclitaxel compared to gemcitabine alone. Investigator assessed DFS was longer for those treated with gemcitabine nab-paclitaxel, and it is important to highlight that this trial was the first trial to use independent review of the DFS, and which is potentially confounded process as the reviewers do not have the access to information used by the local investigator as the pain post-operative radiographic changes after pancreatectomy and CA19-9 level. Follow-up presented This trial was widely interpreted as the negative one because of its fail to reach the significance of the primary endpoint. Superiority of the gemcitabine and nab-paclitaxel over gemcitabine monotherapy. So APECT study along with the SWOG study, they support the use of nab-paclitaxel in patients with the localized pancreatic ductal adenocarcinoma. And then comes PRODIGE 24 trial. Here they comes FOLFIRINOX 5FU 2400 mg per meter square, leucovorin 400 mg per meter square, irinotecan 180 mg per meter square, later reduced to 150 mg per meter square, oxaliplatin 85 mg per meter square every 2 weeks, or gemcitabine 1000 mg per meter square day 1, 8 and 15 of every 4 weekly cycle for 24 weeks. The primary endpoint DFS, secondary endpoint OS. FOLFIRINOX had improvement in the DFS, 3-year DFS, median OS and 3-year OS. So grade 3-4 adverse events they were experienced by FOLFIRINOX were higher as compared to gemcitabine. Improvement in the survival endpoint was impressive. There are several important events in this selection criteria must be emphasized when conducting. So patients who were only considered eligible for randomization after complete recovery from the pancreatectomy, and PS complete recovery, and then PS 0 to 1, CA99 less than 180 within 21 days of randomization. And this trial included patients with most favorable conditions and biological factors, the major gastrointestinal surgery, and therefore OS of this trial is questionable. Overall generalizability of this trial is questionable, as major patient clinical practice do not fit the phenotype of patient within this landmark study. Another notable finding in this above discussed adjuvant chemo trial improvement in the observed OS of patients who received gemcitabine monotherapy alone from CONCO and PRODIGE 24. DFS remained constant, and these findings are likely results of more stringent inclusion criteria and introduction of the multi-agent systemic chemotherapy modified amphotericinox gemcitabine nab-paclitaxel in patients who recurred.